What I presented is actually the teamwork of approximately 80 people that at the beginning of 2011 started to harness the preclinical model of patient-derived xenograft, that is, putting pieces of patient tumor into mice in order to understand why in colon cancer the majority of patients are resistant to what at the time was the standard treatment with targeted therapy, i.e. cetuximab, which is a monoclonal antibody against the EGFR gene. EGFR is the epithelial growth factor receptor. Is one of the most important genes for the survival of normal and tumor cells. The funny things in colon cancer is that this gene, it's never mutated or amplified or translocated. Therefore, it's not a non-co-driver, but still was the main stay of biological therapy. And what we did is, in this huge colony of patient-derived factors, which are patient-derived tumors, which are really avatars of real patients, and we have 1,000 now of them. And the reason we wanted so many is because we were interested in finding molecular aberration that may be present in the population at very low frequency, like 1%, 2%. Because precision medicine is this. Precision medicine stands on exception. And so we wanted to see the exception. And we used cetuximab, therefore doing a trial, to identify the patient that were not responding to cetuximab in the hope that they had some of these new aberrations. And lo and behold, the first one we found was HER2. HER2 is a cousin of EGFR, and it's a well-known oncogene because it's found in breast cancer in approximately 15 to 20% of breast cancer and in approximately 10% of gastric cancer. In colon, it's much less, it's 3%, but still 3% of a large, one of the second most frequent tumor. It's a lot of patients. Just to give you an idea, in 2030, there are going to be 2.5 million of patients with colon cancer. 78,000 of them will have HER2, so it's still a large number. Okay, so we found that HER2 was amplified, meaning that there are many copies of the genes. We also find that to really be addicted for the tumor, that if you shut down the HER2, the tumor will shrink, at least in the PDX, in the avatars. You need to have many copies. We eventually in the clinic find out that the threshold for being addicted is around 10 copies of the gene compared to one, obviously. So once we found that, what we did then was to do the preclinical trial in the 7 avatars in which we found the HER2 amplification. And the interesting thing, which we would have missed if we hadn't gone into the preclinical area, was that in order to shut down HER2 and induce tumor shrinkage response in colon, you need to do a combination of lapatanib, which is a small molecule that inhibits both HER2 then EGFR, which is also called HER1, so the two cousins, and trastuzumab, which is a monoclonal antibody against HER2. And that kind of is unusual because in breast you just need one of the two. It works better if they're two together, but they still work as a monotherapy, not in colon. And this is kind of interesting. This is what we are finding with target therapy, that the same aberration, molecular aberration, a mutation or an amplification, the same one in the same gene behaves differently in different contexts. What happens in breast doesn't necessarily happen in colon or in gastric, even if the same gene is involved, okay? And so I think that this underlines the beauty of using, as we did, the mice avatar as potential patient. After having observed that, we then went to the clinic. First, we established a specific diagnostic criteria for defining HER2 positivity in colon cancer. And then we treated patients that were positive with the combination of lapatanib and trastuzumab. We treated 33 patients, had 70% of patients, 23, that had a clinical benefit with a tumor shrinkage of some kind for a certain time of duration. And 10 of these patients, i.e. 30%, had an objective response by RECIST, meaning that their tumor dropped more than 30%. Actually, in the majority of cases, it almost dropped to zero. In 2 cases, we had complete response. In one of these 2 cases, this lady, she's still alive and without evidence of disease 36 months after having started treatment. And this is very exciting in colon cancer because, just to give you a comparison, if you use chemotherapy in these patients that were at their 4th, 5th, even 11th retreatment, you get less than 5%, and we got 30. And if you use immunotherapy in another niche of patients, which are the patients that have macrosatellite instability, which again are only 3% as the HER2, you get again 35-40% response. So certainly we have found something. Nobody has ever treated colon cancer with target treatment alone, and we have established that you can do that and you can have really exciting results.